Our webinar is titled Iris Registry, helping you report PQRS and clinical quality measures for the Medicare EHR Incentive Program, presented by the American Academy of Ophthalmic Executives and the American Academy of Ophthalmology. It's now my pleasure to introduce your program moderator for this evening, Brandy Brooks. Brandy Brooks, Director of Marketing for the American Academy of Ophthalmology. Brandy will now introduce our speakers. So, Brandy, welcome to the program.
Thank you very much. Hello, everyone, and welcome to our Iris Registry webinar. This is the third in a series of webinars to introduce Academy members to this very important strategic initiative. If you happen to miss the first two webinars, they've been archived on the Iris Registry website, and links will be provided at the end of today's presentation. This evening, we're fortunate to have with us three speakers who have been key in the development of the Iris Registry. First, we have Dr. William L. Rich III. He is chair of the Registry Measure Development Work Group. Since 2005, he served as the Academy's Medical Director of Health Policy, and he currently practices as a senior partner in Northern Virginia Ophthalmology Associates. Next, we have Dr. Michael F. Chang. He's the Knowles Professor of Ophthalmology and Medical Informatics and Clinical Epidemiology at Oregon Health and Science University. He's also chair of the Academy's Medical Information Technology Committee, and he's a member of the Academy's Pediatric Strabismus Annual Meeting Program Committee. Finally, we have Dr. Flora Lum, who's the Executive Director of the H. Dunbar Hoskins Jr., MD, Center for Quality Eye Care, and the Policy Director, Quality of Care and Knowledge-Based Development. Before I turn it over to our speakers, let's just quickly go over today's agenda. So we're going to start out with a quick introduction to the Iris Registry. Then we'll talk about the changes that are happening in 2014, including changes to PQRS, meaningful use, the 2014 certified EHR technology, and the value-based modifier. Then we'll talk about what the Iris Registry can do for you, either if you have an EHR system, and even if you don't have an EHR system. Then we'll talk about the value of the Iris Registry and how to participate in the Iris Registry. Finally, we'll end with a series of questions and answers posed by you, the audience. And today we have more than 1,000 people in the audience, so we won't be able to get to everyone's questions, but we'll answer as many as we can. And now I'll turn it over to Dr. Rich.
Yes, Iris Registry is the nation's first comprehensive eye disease clinical registry. Iris is intelligent research and sight. It enables us across the country to use clinical data to improve care delivery and patient outcomes. It helps us meet the requirements of the federal PQRS program, streamlining the way to quality-based payment bonuses. It uses scientifically valid and HIPAA-compliant methods to collect data from patient records directly from the EHR. This is a quote from David Park, our EVP, and I totally agree with his assessment. The Iris Registry will represent a seminal change in how the medical specialty of ophthalmology will improve performance and outcomes while shortening the timeline to the dissemination of important clinical knowledge, research, and the results of drug and device surveillance. We're now going to go into the changes in 2014, and there's tons of them, as you know, and it's very confusing. This has probably been the most confusing area I've seen in health policy and regulation in the last 20 years. And to guide us through, I'm going to turn this over to Flora.
As Dr. Rich noted, this is a year of many changes and complexities. As you know, it's 9 measures this year in order to earn the bonus that will come. And if you're less than 9 measures as you report to claims or registry, you would be subject to the measure applicability validation. The measures have to be across 3 quality domains. That's another change, and I will go over the quality domains in the next minute. You can also report your clinical quality measures through a 2014 certified EHR technology. That will also count for PQRS this year. If you report 3 measures, 50% of the time, you avoid the penalty that would come in 2016. But if you don't participate in PQRS this year, there will be a 2% penalty following in 2016. So it's important to note that what you do this year, 2014, will affect your payments in 2016. So as I noted, there are the measures have to fall into 3 quality domains. These have been developed by the National Quality Strategy and are being used by CMS to align all the measures. So they have categorized every PQRS measure and every clinical quality measure into one of these 6 quality domains. And as I said, you have to submit 9 measures across 3 different quality domains in order to qualify for the incentive. Next, I want to go over the PQRS measures, and we will review this later on, but the IRIS Registry will allow you to report PQRS measures either through an EHR, certified EHR technology, or without an EHR by using these measures. So I think that you are well familiar with these PQRS eye care measures, which the Academy had developed and submitted to CMS. So there's no changes in these 9 measures, and they do span 3 domains. So you could qualify for the incentive by reporting on these 9 eye care measures. If one of these measures does not fit your patient database, there are additional measures like melanoma measures, which oculoplastic specialists can report on, and then some general measures like documentation of current medications or tobacco use. So combination of these and the 9 eye care measures should be able to qualify you for the 9 measures across 3 quality domains. We also offer the Cataract Measure Group. That will be through the IRIS Registry, as we have offered in the past with our previous registry with outcome quintiles. So this will probably be the easiest way to qualify for PQRS in 2014. There's 20 patients that need to be measured with these 4 measures. And it has to be done, the cataract surgery has to be performed before September 30th of 2014. It involves patient surveys, which you can provide to the patients, but the patients return the surveys to the registry. The registry will collate the surveys and report them to CMS on your behalf. So we think this has been a popular way to report for PQRS in the past, and we expect it to be popular this year as well. So for the Medicare EHR incentive program, the big change is no matter what stage you are in, you must have 2014 certified EHR technology. And this is a little bit tricky because you have to make sure that your vendor has been certified according to the Office of the National Coordinator certified product list. So that we will have a link to that in a later slide. But it's important what version of the EHR technology that they are certified on. So you may, if you don't know already, you need to ask your vendor and when they will upgrade you. We found that at this point in time, this year, very few people are really on the 2014 certified EHR technology. But fortunately, there's a 90-day reporting period for clinical quality measures. So you still have time this year, and we can still report PQRS for the entire year, even if you haven't had the certified EHR technology for the entire year. In addition, in Stage 2, some changes are increases or changes in how many functional objectives for core, how many menu objectives, and then meeting the 9 quality measures across the 3 domains. That is new for Stage 2. So I want to review what the clinical quality measures are. And these clinical quality measures, again, are needed to meet the meaningful use incentive program, as well as they can be used to qualify for PQRS this year. These are the eye care measures. Unfortunately, they don't include all of our ICAM measures, so there are only 6 across 2 domains. So in order to meet the 9, you really have to add some non-eye care measures. And I'll review the non-eye care measures now. These are an additional 6 measures. So the IRIS registry will actually extract from your certified EHR technology 12 measures in all, and that gives us a safety margin because we want to submit 9 of the best performing measures for you to qualify for PQRS. So I will go through in detail these non-eye care measures because these are probably the ones that you are least familiar with. So closing the loop, that means when you refer a patient out to another subspecialist or another medical specialist, that you receive a report back. So that will count how many of the patients you referred you received a report on. The second one is documenting current medications, and we've seen that before also in the PQRS measures. But it means that you have documented to the best of your ability what the list of current medications that your patient is taking. The third one I know is less common, but there may be practices that do take weight or height or ask patients or have an associated general practice or internist notate what the BMI is. So you will get credit if you do have a documented BMI in the record, and then added to that, if the BMI is abnormal, you have a follow-up plan. We realize that's not very common, but it is a possibility that some practices may be able to use this measure. So that's why we've included it. Tobacco use screening and cessation, I think this one can be broadly applicable, and it's the percentage of patients that you screen for tobacco use. So you may not do the cessation counseling, but you will get credit for screening the patients. Now, if the patients are smokers and you give cessation counseling, you get extra credit for that as well. But you will be counted for performance just by screening patients for tobacco use. The second one is use of high-risk medications in the elderly, and there's a list of medications that are considered high risk. Unfortunately, we do have one ophthalmic medication that's included in the list, and we believe it's an error, and we have flagged it to CMS, but unfortunately, they won't be able to correct it until next year, and that is Acular. And that was just by mistake. I think that they included the ophthalmic formulation. But again, it's the percent of patients that are prescribed these high-risk medications. And since we are still in pay for reporting, the performance on this measure should not hurt you, I think. The last one is controlling high blood pressure. So despite the title, it's not exactly looking at your management of blood pressure, but it's saying how many patients of yours can have a diagnosis of hypertension, and then you would get credit if their blood pressure was normal. And we realize that not everybody takes blood pressure readings in their office, but it is something that some practices do on a routine basis. So we have included that. Now, in the value-based modifier program, that's probably a new program to a lot of you. But what we want to highlight is that in 2014, it will affect you if your group has 10 or more eligible professionals. Now, eligible professionals includes not only ophthalmologists in your practice, but optometrists, nurse practitioners, physician assistants, so occupational therapists. So you may reach this threshold more easily than you would have thought of. So as we said before, if you don't participate in PQRS in 2014, there's a 2% penalty. This is an additional 2% penalty. So you have a 4% payment adjustment if you're a practice of 10 plus eligible professionals this year and if you don't successfully participate in PQRS. Now, the definition of successful participation means you don't actually have to meet the threshold of meeting the incentive, but you must, at least half of your eligible professionals must avoid the penalty. And as we talked about before, avoiding the penalty includes at least reporting on 3 measures 50% of the time. And at least for 2016, you will be, we'll talk about how this value-based modifier is constructed, but quality tiering will be included in that, but there will not be a negative adjustment in 2016 for practices of 10 plus. There could be a negative adjustment for big practices of 100 or more, but I don't think that will affect probably people on this call. Again, this kind of shows the effect of PQRS participation. So as we said, if you don't participate in PQRS and you're a 10-plus group, 10 to 99 eligible professionals, you will receive a 2% penalty in 2016. And then if you are a PQRS reporter, then you could have a positive payment adjustment or no adjustment based on the value-based modifier. And this is a diagram of how we think that the value-based modifier amount will be calculated. There are 2 major components to it. One is quality of care, and that's based on your, actually the performance will count for you if you're a practice of 10 plus eligible professionals. They will look at your PQRS measures or clinical quality measures and come up with some composite score based on your performance. And then there will also be a cost component that looks at per capita cost for specific conditions. And from there, CMS will determine a value-based modifier amount. And this will apply again in 2016 for the 10 plus eligible professional practices. Again, this is kind of the tiering they're talking about. They will categorize people into low, average, high quality, and low, average, high cost. And the modifier adjustment in your payments will depend on both of these factors and where you would get categorized in terms of quality and cost. So at this point, I'd like to turn it over to Dr. Rich.
Thank you, Flora. I'm going to have Mike come in and pick up the ball to talk to you about having an EHR system, and I see a couple questions already up. And if you don't have an EHR system, Mike?
Bill and Flora, thank you. This next set of slides deals with what the IRIS registry can do for you. And one of the benefits of my speaking third is that I've been monitoring some of the questions that have come in. And let me just try to answer a couple of them up front because they're relevant here. If you have an EHR system and if you don't have an EHR system, the background here is that to qualify for meaningful use, you have to use a certified EHR system. And there are 2 criteria for certification. There are the 2011 criteria and the 2014 criteria. And the 2014 criteria are more extensive than the 2011 criteria for certification. And so for the slides here, you have to be using a 2014 certified EHR to be relevant here. So this slide talks about if you have a 2014 certified EHR, and the next slide talks about if you do not have a 2014 certified EHR, or if you don't have an EHR, period. And so how do you know whether you have a 2014 certified EHR? Flora has a slide at the end that has a website that you can go to check about that. Okay, so on this slide, we talk about what the IRIS registry can do for you if you have a 2014 certified EHR. So bullet point number 1 is that it lets you report on behalf, the IRIS registry can report on your behalf to be eligible for the PQRS incentive payments in 2014. So in other words, the IRIS registry is a certified, or will be a certified EHR data submission vendor for PQRS purposes. Okay, the next bullet point here is that the IRIS registry can report on your behalf to satisfy the requirements to report for meaningful use clinical quality measures. Okay, so as Flora had showed before, the meaningful use clinical quality measures are very similar to the PQRS quality measures. The next bullet point here is that IRIS registry can satisfy the meaningful use stage 2 menu functional objective to report to a specialized registry. Okay, and the last point here is that IRIS registry can satisfy the requirements to participate successfully for PQRS for the value-based modifier. Okay, so those last couple slides that Flora showed. So these are purely benefits from the perspective of PQRS and clinical quality measures, and obviously does not touch on the whole issue of quality improvement. That's one of the other focuses of IRIS registry. Okay, so this slide is what IRIS registry can do for you if you have 2014 certified technology. Now, this slide talks about what IRIS registry can do for you if you don't have a 2014 EHR, or in other words, if you have no EHR at all. Number one, can still report on your behalf to be eligible for PQRS incentive payments for 2014. And number one, through the Cataract measure group that Flora had talked about. And number two, through the 9 individual PQRS measures. Okay, so next it can report on your behalf to avoid PQRS payment adjustment in 2016 through 3 individual PQRS measures. And lastly, it can still report on your behalf to meet the requirements for reporting on quality measures for the value-based modifier. Okay, so just talking a little bit more about value of IRIS registry. This slide basically talks about a lot of different programs going on. Number one at the bottom is obviously your individual performance improvement dashboard. Okay, now this is a function of the IRIS registry that lets each individual provider look at how they're doing compared to other providers around the country or in your area. Okay, so on various quality measures. Number two is PQRS, meaningful use, quality measure reporting, meaningful use stage 2 menu reporting to a registry, and lastly is quality measures for the value-based modifier. Okay, so all these different programs, and in principle, you could report all of these things individually if you did them yourself. But the point is that IRIS registry takes care of all this. And so in doing that, what IRIS does is it takes data extracted from the EHR, goes into the registry, and once you've got that into a single registry, it can satisfy all these multiple regulatory reporting requirements through a single registry. So in principle, would make things much simpler for all the different practices. Okay, and this slide basically puts together a lot of those numbers that Flora had talked about before, and it basically shows the overall impact of Medicare's value-based purchasing programs on providers over the next, from 2013 to 2018. So here on the left side are all the different programs, meaningful use, PQRS, and the value-based modifier. And here we've got 2013 to 2018. And the point of this is that meaningful use penalties are not the only penalties that ophthalmologists have to worry about. So just as an example of that, in 2015, if you didn't participate in meaningful use, PQRS, or the value-based modifier, you would see a 3.5% cut to Medicare payments on top of whatever else SGR has in store. And by 2018, that would go up to 5 to 6% or more, depending on what happens, for example, with the value-based modifier. Okay, so the point of this is that all these little things add up. And the IRIS registry may be one mechanism for submitting to try to satisfy all these requirements. And this slide just puts some tangible numbers based on all the percentages in the previous slide. So, for example, per physician, assuming $300,000 of Medicare revenue per year, in 2013, that minus 0.5% would that 0.5% would translate to a $1,500 bonus. By 2015, that negative 3.5%, you would avoid that $10,500 penalty, and by 2018, it would jump to this number here. And for a 4-physician practice, based on the same assumptions in the last slide, we're talking about 2013 a $6,000 bonus, and in 2018 avoiding a $72,000 to an $84,000 penalty. Okay, so just to summarize here, a couple points about what we've talked about. Number one, the IRIS registry reduces regulatory burdens for your practices by updating and submitting the data that's required to meet all these new criteria and keeping you informed of changes. So in other words, we found that for a lot of people, it's a lot of work to keep track of PQRS requirements and does your EHR qualify and how do you manage all of that. And so IRIS registry would take care of all of that for you centrally. Number two is that there are clear financial benefits for practicing ophthalmologists. And at number three, a lot of people have asked the question, well, who owns the data in the registry? And the answer to that is really simple. It's that you own your individual data. And the IRIS registry does not submit any data to CMS unless you authorize that submission. Okay, so let me stop here. And Bill, I'm going to turn it back over to you to talk about the final part of the webinar.
Sure. And before we do that, I'd like to stress to the audience that today we're really emphasizing the regulatory aspects of IRIS. But basically, this started as a way to improve your outcomes and the quality of care that we deliver. So I strongly encourage those of you who haven't gone through the first webinar to go back and review that, where we really stress the professional improvement. Let's talk about learning more about IRIS and how to sign up. Basically, the more data that is collected, the more effective IRIS registry will be. So to encourage you, the Academy is offering participation in the registry free for the first 2,000 members and up who have their EHR system integrated. It was just announced at the board that we're actually going to extend that because our goal was to have 2,000 members by 2015, 2016, and we're going to reach that before our launch on April 1st. So the number of free memberships will be extended indefinitely. To participate in the incentive programs via EHR system, PQRS, EHR, value-based modifier, the whole alphabet soup that you just heard, you must contract with us by June 1st and have your EHR system mapped by August 1st. I saw some questions already about how you've contracted and ready to be mapped, and then come back and help you calculate your measures. And to participate in the 2014 incentive programs through the Cataract Measure Group, in the qualified register, you must contract us by August 1st so that you have enough cases to qualify. How do I sign up? Well, if you email us at irisregistry@aao.org, you fill out a questionnaire, and Andy Kwong will get back to you and review and sign some contracts. You'll be placed on a reservation list in order of receipt of the signed contracts and questionnaires. Practice will then be contacted in order of the reservation list to receive the software for installation. Reservations allow the Academy let new users start while maintaining a good user experience. While you're waiting, I would strongly encourage you to contact your EHR vendor, or if you haven't bought one yet, to inquire to make sure that the EHR is going to facilitate the use of your EHR with the registry. And you also might want to ask if there's any additional fees to you. Run into a couple vendors that are charging practices, so you want to make those inquiries up front, especially if you haven't bought an EHR yet. Again, the important deadlines, if you have a 14 certified EHR system, and again, a lot of these EHR companies are really flailing to get their certification done. You can find out at this if you go to this website and select 2014 We want you to submit a contract by June 1st. We want to get you successfully mapped by August 1st in order to meet all these incredibly complex regulatory requirements. So, a couple questions already. If you're not using EHR, System for PQRS reporting, you can submit a contract, and if you want to report on the measure group, like it's done before with outcomes, and submit a contract by October 34th with reporting on 9 individual measures. One thing I'd strongly encourage you to do, those of you that haven't reported on 3 PQRS measures with claims, we're encouraging everyone to do that this year. This is such a huge change in the regulatory environment. It makes me a little nervous that CMS isn't going to be able to do this properly. So just as the belt and suspenders approach, I do recommend that you continue to report by claims. I know my group is. And if you haven't, I sure would for this year. How do I learn more? For more information about the IRIS Registry, visit the Academy's website, aao.org/IRIS Registry, or you can email us, and one of the staff will be answering your questions. For more information about meaningful use of an EHR system in the PQRS, you can also go to the website and look at these 2 links. So in summary, I've been in practice 37 years, and this is probably the most exciting thing that I've seen. And this kind of sums it up. These are the words of Harvey Feinberg, president of the Institute of Medicine, at the opening session in 2008. We are facing very challenging times in healthcare in the United States today. I believe that ophthalmology has an opportunity not only to play a part in the solution to these challenges, but also be an example for the health profession in the way forward. Certainly, if you look at all other registries, joint replacement registries, cardiac stents, they look at the impact of an intervention. This is the first time in all of medicine we'll be able to follow patients longitudinally and look at the impact on our interventions, whether an anti-VEGF agent, a surgery, a laser, or even medicines, to see how they affect the natural course of the disease, the patient's outcomes, and the patient's quality of life. It truly is a game changer. Let's kind of throw it back to the moderator and open it up with some questions. Before we do that, Mike and Flora, we've all been watching some of these float by. Are there any comments you would like to make of a general nature, that some of the ones we've seen before we've gotten to specific questions? Jerry, now let's go ahead with it.
Bill, let me, maybe I can address one thing that you've already addressed before, but it's come up so many times in the questions. If you don't have an EHR, what do you do? And is IRIS Registry available? And I think the short answer, let me try to take a stab at answering at that, and maybe Bill and Flora, I'll be interested to hear what you say to add to that. But the short answer is that IRIS Registry is definitely available if you don't use an EHR. But it's harder to use. The reason, and just to answer one of the questions that I've seen come up a few times, how does data get into IRIS if you don't have an EHR? Well, you have to put it in manually, meaning to go into a web interface to the IRIS Registry and enter in all those steps. But once you've done that, it would work the exact same way. It's just the time to enter that. But it's definitely available, and you can do all the things that we talked about.
Exactly. And the web-based portal is how device registries work. A nurse inputs the data in the operating room. But again, everything we do, most of the things we do are done as an outpatient or in the office. And so the burden of inputting data on the web portal is upon you and your staff. So why don't we turn it back to the moderator and get to some questions. Thanks, Mike.
All right, thanks. So we do have an awful lot of questions, so let's just get started. The first one, is this for Medicare patients only?
Basically, yes. The quality reporting and the bonuses and penalties are only applied to Medicare patients. However, the quality improvement, the outcomes of treating a glaucoma patient, a diabetic, all of your patients are going to be in there. So the financial benefits and the financial reporting only applies to Medicare. But you'll be able to track your performance, for instance, in treating an African American with glaucoma across all your payers. I hope that it helps.
Great. The next question. Go ahead.
Andy, do you mind if I add one thing to that? That I don't think this is going to be saying anything beyond what Bill said, but this is an issue that's always confused me. And what as Bill said, basically some of these incentives apply only to Medicare patients, and some apply to all patients. But what I've heard from talking to some EHR vendors is that sometimes if you query the EHR and do their reporting, that I've heard that some of the EHRs are reporting for all patients, and you have to tell the EHR that, for example, you want only the Medicare patients. And so that would just be one thing to watch out for in reporting. And the second thing is that, and Bill, this is exactly what you said, that something like Iris Registry, you can query for your patients in incredible detail to look for how different subgroups are performing compared to each other, and that applies to all the patients, not just the Medicare ones.
Yeah, and also we should clarify that this only applies to Medicare fee-for-service. The bonuses and penalties don't apply to Medicare Advantage plans. Isn't that correct, Flora?
Correct.
Yeah. Okay.
All right. The next question is related to the reporting period for PQRS. There's a question about, is the PQRS reporting period also a 90-day reporting period in 2014? The questioner thought that PQRS was still at 1 year.
That is correct. Yeah. That is correct. That PQRS is for the entire reporting year. However, we just received clarification from CMS because of the transition period this year for 2014 certified EHR technology. As I said, a lot of people have not gotten it yet. The vendors have not had these in production. That they will accept the clinical quality measures are for a 90-day period. And then you can use that same EHR technology to look back the entire year to report for PQRS. But it's with the understanding that you haven't had that certified EHR technology for the entire year. But even through that, we can use the EHR technology to look back from January 1st through December 31st.
And that's absolutely key, because before there was a growing fear that if you didn't have the certified EHR, or if it wasn't certified until later in the year, you wouldn't be able to report your measures. But if you have the EHR, it can actually calculate all your measures back to January 1st. So the questioner is correct, and that it's for the year, but the certification is not.
Okay, great. The next question, do I have to meet the 9 measures, or can I just meet the cataract surgery measure to count for the 2014 reporting?
Laura?
Yes, you can just use the cataract measure group. As I said, the surgeries have to be performed before September 30th. You have to do 4 measures on at least 20 patients, and the registry will collate the patient surveys and report the scores back to CMS.
I think we should point out there are a couple of other questions on here, Flora. Do they have to do the surveys themselves? Do they have to do the quality of life function themselves?
Right. So the way it's structured is that the registry, that for convenience, your practice can give the patient at the time of the pre-surgical evaluation the forms, but all the forms come back to the registry, so we'll take the burden of collating them and scoring them and putting them together for the group composite. It's 20 patients per physician or per eligible professional. It is only attributable to the operating surgeon because they are measures of the quality of the surgeon's performance. And then the forms are very exact. There can't be any modification of the forms. They've been vetted and validated in the literature.
Exactly. And apropos, just to stay on the same question, one of the folks asked, well, I have 2 docs that are going to want to report on cataract and one that wants to report on other quality measures. Can you do that? Absolutely. you don't all have to report on the cataract or all on the 9 measures.
Great. Okay, so the next question, does a practice have to sign up before submitting PQRS measures, or does simply sending the codes to CMS qualify you for the incentive?
Well, why don't you tackle that first, and I'll hop in.
So I assume this is sending in the codes for claims. So through the claims, you don't have to sign up. But you would have to submit codes for 9 measures throughout the entire reporting year and meet a 50% reporting threshold. We think that will be pretty cumbersome for practices this year. So that's why we are offering this option through the IRIS registry to be able to report for you, either through your EHR or non-EHR through the Cataract Measure Group or through 9 measures through the registry, which is retrospective and thus less burdensome than the claims process, which, as you know, is a prospective process.
I think that's absolutely correct. And Mike, if you have anything, just hop in there. But again, we still are encouraging you to report 3 by claims just in case the government doesn't pull this off. So I would encourage you to submit 3 by claims. My group looked at this, and our office manager did, and we came to the conclusion, as Flora just suggested, this was impossible to report 9 measures by claims. But I would report 3 no matter what.
All right, let's move on to the next question then. We do have a lot of transitions this year, including ICD-10, and someone is wondering how PQRS reporting requirements might change with the transition to ICD-10.
Mike, do you have any thoughts on that?
I actually don't know. I've wondered about that too. I don't know that they're going to change per se. I mean, I think that the way that the PQRS measures are calculated may change a little bit, but I don't think the requirements in themselves are going to change.
No.
I think that's correct, and we've already included ICD-10 codes in the extraction process, so we can either collect ICD-9 or ICD-10 codes where applicable.
Great. Next up, is IRIS Registry compatible with Epic Kaleidoscope?
Well, that's interesting. That's very interesting. I'm going to defer that to Michael. We've been trying to work with Epic, and Michael is head of the Medical Information Technology Committee, and he does have Epic at Oregon. Michael, what are your comments?
I think the answer to that is IRIS compatible with Epic Kaleidoscope is in my mind, it's a definite yes and no. The yes part is that ultimately it's going to work with IRIS. IRIS is going to work with Epic. So the yes part is that in principle it can work with any EHR. And also we've talked with the Epic folks in actually a lot of detail and have several possible ways of connecting Epic with IRIS. The no part is that nobody's done it before, but we're working on it, basically.
Yeah. I think the important thing to stress is that our vendor, we're mapped now to, 27 different EHRs, Flora, and our vendor has mapped to the same one for cardiology, 50 different EHRs, including some large ones like Cerner. So rest assured that there's not an incompatibility with Epic and IRIS. The problem is more of getting their cooperation to do it, and we're working on that very strenuously.
All right. Early in the presentation, Flora mentioned the outcome registry. What is the difference between the IRIS registry and outcomes?
So for the past 4 years, in order to provide our members with a way to report on the registry-only measures, which were the Cataract Measure Group, we partnered with Outcomes at the time, was later acquired by Quintiles, and it was a traditional registry approach where you use a web entry portal and you input your patients, and then you basically you check off if you met the measure or not. And those would be submitted after the year was done, and you would have a chance to look at the data and make sure there weren't address any errors before that got submitted to CMS. But anyway, we because of IRIS Registry, we no longer have that registry for 2014. But that was our previous registry approach to help people participate successfully in PQRS.
In other words, we're going to be doing it through IRIS this year. Yeah.
Right.
Great. Our next question is about the eligible providers. So is the group of 10 providers just for eye care, or would it refer to the entire group of doctors of every specialty in an academic health center?
I think we'll all take a hop at that. If you're an eye care group, it includes your ophthalmologist and optometrist, not your technicians. Michael?
That's my interpretation, too.
Laura?
Right. Yes, that's correct, and eligible professionals. It would depend on how you're reporting. There is that group reporting option where you could report as an entire academic medical center or hospital as well. And that would depend on a lot of reporting by the primary care and internist. But it depends on how you're approaching the reporting and what group TIN you're using to report under.
That's absolutely correct. And so I'm not sure what the intent of the question is, but if you're in a large integrated group in an academic center, the odds are that you're already qualifying for PQRS, the value-based modifier, under the group thing, which relies heavily on primary care measures. So you're probably not even, it's pretty seamless if you're in a large group like that.
All right, great. The next question. So if a practice is falling short of meeting the requirements for any of the measures, do IRIS Registry users get warned and instructed on what needs to be done to change to meet the requirement?
That's a great question. Flora and Mike?
First, it is a pay for reporting. So as long as you report on the measures, CMS is not actually qualifying your incentive based on your performance rate. The performance rate does come into play actually for the value-based modifier, but if you're not subject to that, the performance rate actually won't be of significance in determining if you get the incentive payment. However, we do provide feedback. We will have a dashboard that you can look at constantly to see how you're performing on the measures and to compare with the other practices in IRIS Registry. So you will get that continual feedback and input on how you're doing on the measures.
Not only that, but initially you'll be surprised that you're not doing well on a measure, and you'll say to yourself, well, I do that all the time. So the vendor staff will be able to show you that in the first time you start reporting, it's usually that you're not actually reporting all the elements that you should, or you're not, right. You're not finding, and the EHR is not finding the element. And so there is a learning curve and a feedback by the staff that says, listen, you say, I'm not doing well on this measure, and they'll tell you why. And then you can actually change the way that you document things in your record to make sure that it is extracted through the EHR seamlessly into the registry.
Right.
I think one of the challenges with EHRs is that doctors can use them so inconsistently. And, everybody can record things in a different place in the chart, and then you never know where to look for the data. And I think that one of the long-term benefits of a project like IRIS Registry is it can get people to behave a little bit more consistently, so we all know where to look to get the right information.
That's actually, I really do think that that's going to happen, Michael. For instance, where do you find the central macular thickness in an OCT? It's all over the place. It's in the thing, it's in the report. Perhaps it would be extractable if we actually put it in a little report that you have to write for Medicare. There's a number that would be easily extracted by the EHR. So I do think you're going to find some common ways of recording different tests and fields, especially when there's a digital aspect to that should be easily extracted.
All right, the next question. So a few times today we've mentioned the concept of mapping to the EHR. What do we mean exactly by mapping?
Well, I can't use an iPhone, so I'm going to need to turn this over to Michael.
That's a good question. We probably should have talked about this up front a little bit more. That in order to get data from the EHR, IRIS Registry has to know, well, we have a table of all the relevant data elements to calculate all the required measures. And all the required measures are, number one, things like PQRS, and number two, various quality outcome measures that are developed for each subspecialty. And so we've got a table of all the different data elements that need to be extracted from the EHR. And so what mapping means is that our registry vendor, which is a company called FigMD, works with the individual practices and with the EHR that your individual practice uses, and then figures out where in the EHR's database each of those data elements is stored. And that's the process that's called mapping. And so really what it means is figuring out where individual doctors store those data elements in their own EHRs. And obviously, once that's done for one EHR, it becomes easier for the next doctor who uses that EHR or for the next practice that uses that EHR. And as Bill mentioned, there have been really a very large number of ophthalmology EHRs that have been mapped already because different practices that we've contracted with have been using those EHRs.
There's a question here also, and again, I refer you back to the original webinar about quality improvement, but there's a couple questions that can I actually mark my progress throughout the whole year? Yes, you actually can compare your results not just on PQRS, but on outcomes measures for diabetic macular edema, glaucoma, rates of visual field loss, and things like that, to a national database, a regional database, or within your own group. I have a group of 10. We don't even know how we compare to one another. So it is a very, very powerful tool to compare yourself to your peers.
Right, the next question is back to the Stage 2 certification. So if my EHR vendor is telling me that they should receive their Stage 2 certification this month, so in February, would they be eligible to participate this year, or must it be the full year of 2014?
No, for Stage 2 this year, for 2014, it's a special 90-day reporting period. So they realize there's a transition, and as long as you get your version and you've implemented it and the CHR, certified EHR technology, and you report for that 90-day period calendar quarter this year, you will be eligible for the Meaningful Use Incentive Program, as well as we can help you do the PQRS reporting for the entire year.
I see another couple questions, Flora, getting back to the cataract. So if you do report on 20 patients through the registry in your cataract, it doesn't have to be 20 patients, it could be 20 eyes. You don't have to record other PQRS measures. It's interesting, that question keeps coming up. And we are HIPAA compliant. Another question?
Yeah, another question about the sign-up process. So if you're in a group, do the individual doctors sign up individually, or does the practice sign up as a whole? Does everyone have to participate?
We do the sign-ups by practice. However, you can indicate which professionals in your practice are participating or not. That makes it easier because it's on an EHR basis, and we can go in and integrate on the practice level.
All right, the next question is for practices that do not have an EHR. They're wondering what the anticipated start date is for the portal to IRIS for the cataract measures.
So this is a little bit dependent on CMS because we have self-nominated as a qualified registry for 2014. However, CMS will not announce the list of qualified registries until a little bit later this year. So we anticipate it will be in about April-May timeframe this year. But we are aware of the deadline that you have to have the surgeries performed by September 30th, and we'll do our best to have the forms ready so that people can start reporting to identify which 20 patients they want, and then they can give those pre-surgical evaluation surveys to the patients.
Again, before the question came up, 20 eyes or 20 different patients?
It is 20 different patients.
Sorry, I misspoke.
Okay, we're just about out of time, so one or two final questions. Next up, does the registry automatically extract the information from the EHR for all of the measures?
Michael?
Short answer is yes. And obviously, if the measures change over time, or if different doctors change the way they document over time, you will have to work with the vendor to figure out that mapping. But the short answer to that is yes, it can handle everything.
Yeah. So you may want to comment. There's a bunch of questions that relate to which EHRs we've been mapped. And could you tell the attendees where they can reference the kind of the scorecard we're putting together? Which ones we've mapped? Which ones are cooperating? And which one are charging fees to the best of our knowledge?
Yes, we're planning to put up like a vendor scorecard so you know that, yes, which ones have been integrated with or mapped with the IRIS registry and which ones that we know are charging fees or not. Obviously we said the IRIS registry does not charge any fees for this service. And that will be on the website, www.aao.org/IRIS registry. So there'll be a list of the vendors that we have successfully mapped to there.
Okay, so we're out of time for questions today. I know that there are a number of questions that we did not have time to answer. We do have an FAQ area on the IRIS Registry website. Again, that's at www.aao.org/IRIS registry. And thank you again to Drs. Rich, Chang, and Lum, and thank you for all of you for taking time out of your busy schedules to participate today. If you do have any questions that you aren't finding answered on our FAQ page on the IRIS Registry website, you can also email your questions to irisregistry@aao.org. Thank you very much.
Thank you, and thank you to everyone that listened in.
All right, and again, thanks everyone for a terrific presentation this evening, and we'll pass along just a couple of closing thoughts here before we wrap up our program for the evening, and that will conclude our webinar titled IRIS Registry, Helping You Report PQRS and Clinical Quality Measures for the Medicare EHR Incentive Program. It's brought to you by the American Academy of Ophthalmic Executives and the American Academy of Ophthalmology. And we would like to thank all our presenters and, of course, Brandy Brooks, who was your content moderator. Now, a recording of this event will be available. To check the AAO website for information on attaining it. Today's program is copyright 2014, the American Academy of Ophthalmic Executives, all rights reserved.